Welcome back to Medical Grand Rounds. It's my pleasure to introduce today's speaker, our very own Dr. King Holmes. Dr. Holmes is the Fagey Professor and founding chair of the Department of Global Health, and he holds a joint appointment as a professor in the Department of Medicine as well. In addition, he currently serves as the division head, of Allergy and Infectious Disease at Harborview, as well as the director for the Center of AIDS and STDs, having previously held positions as the founding director of the STD clinic at Harborview and the chief of medicine at Harborview for a few years in the 1980s. Also as the chief resident to one William J. Bremner in the distant past. He went to undergraduate at Harvard, medical school at Cornell, and trained as an intern at Vanderbilt, prior to doing his residency and chief residency here, the latter of which were under Marvin Turk at the Public Service Hospital in Seattle. He's dedicated his career to the study of sexually transmitted disease, having contributed broadly to the field and played a major role in the identification, control, and treatment of many different diseases. Published more than 500 papers on the subject, and authored or contributed more than 50 books, all while serving as a mentor to numerous individuals, including more than 30 current professors and many more junior faculty and fellows. He's currently the PI or co-investigator on 7 NIH or CDC-funded grants, including studies on AIDS research, gonococcal surveillance, and circumcision in Africa. Notably, he's also received a number of awards for his research, including the IDSA Alexander Fleming Award for Lifetime Achievement in 2013 and the Canada Gairdner Foundation Award. Finally, he's also a member of the Institute of Medicine and a member emeritus of the Western Society for Clinical Investigation. I heard from a good source that he's also a good guy to ask an ID consult question. So please welcome me in joining Dr. Holmes as he gives his talk, 50 Years of Radical Change in STDs, What Happened and Why, What Will Happen and What to Do About it.
Well, thank you very much, Michael and Lene, for inviting me to give this talk. And it's going to be, I couldn't decide whether to talk about STDs or global health, and I decided to talk about a little of both, hoping to attract some of you either as colleagues when you're faculty or are faculty, or as potential postdocs in the future. So the basic theme is how have these diseases changed so radically, and what's next, and what do we do about it? So when I got started, I suspect many of you who are house staff, or when you were house staff or medical students, had a pretty good idea of what you wanted to do when you finished your training. And I actually, at the time I was in med school and at Vanderbilt, I actually didn't know I was going to go into becoming a VD specialist or a globetrotter. But it just happened. And I'll tell you how it happened and what's happened. So I was in my internship at Vanderbilt, and I had a letter that arrived at home, and it was from the U.S. Navy, Captain Steckline. So I called him up, and I learned I was going to be drafted and assigned to the Mojave Desert to a Marine base. And I pleaded, and I negotiated, and I actually ultimately offered a third year instead of 2 years if they would send me to a research unit in Japan or Hawaii. And he said, well, that's an interesting offer. He'd been calling me boy, and he started calling me son. And I actually wound up being assigned to the Preventive Medicine Unit number 6, which you can see here, in Hawaii. And when I arrived at the desk, there were stacks of reports of incurable gonorrhea in the 7th Fleet. And at that time, I actually didn't know anything about gonorrhea, particularly how to cure incurable gonorrhea. And I also, in a preventive medicine unit, as the epidemiologist, didn't know anything about epidemiology. So I was in trouble. I knew that. So I looked at the book first. This was the only book that was out there on venereal diseases. And interestingly enough, there wasn't anything on incurable gonorrhea, first of all. And there were only about 7 or 8 diseases that were in that entire book. So that was no help. So I went to look further. I called around the world, and I finally went to the University of Hawaii. And the first person I bumped into there in the micro department was Claire Folsom, who had been my TA in a genetics lab when I was an undergraduate at Harvard. And so he agreed to be a thesis chair. And then I met Robert Worth, who was the head of epidemiology. And with me, we worked on a protocol to how to study why gonorrhea was failing and how to do a clinical trial. This was pre-IRBs, and the clinical trial field wasn't very advanced either. And so these were my other people on my committee, and then ultimately I came back to the UW when I knew I was going to be coming here after a couple of years to consult with the head of allergy, Paul Van Arsdale, because we were going to try a mass treatment of STD for gonorrhea to see how that would do after we'd done a lot more stuff. So I went first to the enterprise, and we did 6 weeks of work with the protocol. First, there was a week in port in the Philippines. All the men went overseas. We interviewed them when they came back. There were differences between the married men and the unmarried men in terms of frequency of sex with sex workers. For the unmarried men, 80% had sex during that 1 week tour with the sex workers, and for the married men, it was only 79%. So there was a difference. And the numbers were so huge, it was probably statistically significant. I don't think we analyzed it. So what we found was, when we put the C, the men weren't able to have heterosexual intercourse. So it was a good setting for STD research. And it turned out that most of the gonorrhea came in during the first week, and then the non-gonococcal cases came in later. They weren't doing diagnostic testing. It turned out most of the urethritis that they were calling gonorrhea was really non-gonococcal urethritis, and it didn't respond to penicillin. And that's one of the reasons so many failures. But for the real gonorrhea, actually 30% failed the then recommended treatment with procaine penicillin for gonorrhea. And so we added just probenecid to that dose, which is sort of the maximal dose, and it cured everybody. So when we realized that most of what was coming in was non-gonococcal urethritis, we put together a quick study where we, not randomly, but alternately treated men with nothing, which is what that blue book I showed you recommended. It said it would go away in 6 weeks. Or we treated them with tetracycline for a week. And lo and behold, all the people who didn't get treated still had persistent urethritis, and all the ones who got tetracycline were cured. So it was something you could do in those days and not today. But within 6 weeks, we had shown that we had a new treatment guideline for gonorrhea in men, and a new one for non-gonococcal urethritis in men. That was adopted by the Navy, then the military, then the U.S., and widely. And the gonorrhea treatment recommendations lasted for about 15 or 20 years, and the tetracycline for NGU is still the current treatment today. So then we turned the attention to the sex workers. And first thing we found, going to the clinic for the sex workers in Olongapo next to Subic Bay, was that they were treating gonorrhea with bicillin, which is what you use for syphilis, but not for very low levels to cure syphilis. But it does nothing for gonorrhea, but it's a great way to select resistant strains of gonorrhea, which is why resistant gonorrhea had emerged in the Philippines. And then the second thing I found was probably the worst thing I've ever seen in medicine, and that was the doctora who was doing the exams of the sex workers. About 500 per day would come through for a vaginal speculum exam. She'd put the speculum in, take a swab from her assistant, get a specimen, give it back, take the swab into a bucket of water next to her, swirl it, then the next sex worker. And I saw her do this with 500 sex workers. So we bought an autoclave, and we bought 500 specula, and then rebuilt the clinic, and then we built a small hospital next to the clinic. All that took about 3 months and then 6 months, where we could do inpatient trials of treatment for the women. And we then came up with a regimen for women that was effective. It required a little higher dose than for the men, interestingly. And then through doing this, I had to work with the Nightclub and Barrooms Association, you see here. And this was an interesting group, I have to tell you. This is me sitting with them. This is the mayor. And it took some work, but they agreed to doing all this. And at the end, we decided we would try a mass treatment of all the sex workers. That's why I came back to work with Paul Van Arsdale and what was the way to do this safely. We treated 5,000 sex workers over 1 week in a gymnasium with ampicillin plus probenecid, and it really had an amazing effect on lowering the prevalence of gonorrhea in the sex workers, and it lasted for about 2 months. And then it was right back to where it had been. which is one of the reasons we don't do mass treatment in communicable diseases like this very often. So after that, I came to the UW because it had the best infectious disease program in the country, I thought, considered UCSF and Yale. Interestingly, it was a small division. Then we had, I think there were 4 or 5 MARV specialists in ID at that time, but they were all terrific. And I thought, that this would be a good field to get into, continuing work in STDs. Marvin became my mentor. And this was an era where, oral contraceptives and the IUD had just started. Global urbanization was occurring. It was post-Stonewall. The sexual revolution was underway. The war was still going on, and the World War II baby boomers were reaching late adolescence and young adulthood. So this is the epidemic spread of STIs. And there were only 4 or 5 other researchers in the world who were really doing interesting work. So this was not a crowded field, and I thought this would be a good one that we could really get in. And I actually thought at the time that it wouldn't be that difficult. It would be taking a few years. We'd need to do a little help, but with a few diagnostics and a few treatments, it would be solvable. So hence I wrote my first book. And this was the first book. And it sold out pretty quickly. And and it was translated to Spanish, and they got it right. This says, a current guide for sexual emancipation. And that was sort of what we had in mind at the time. We weren't talking about condoms. We really thought this would be solvable. They wanted to do a second edition, and I thought my career could go that way or another way, but I decided, I'm beginning to think about the second edition now, though. Today, however, I know how foolish I was, and today there are 35 known STD pathogens, 36 I think in recent months, and over 35 STD syndromes that are caused by these. And in addition to these pathogens and different syndromes, there are multiple research tracks. In the pathogen area, we talk about biology. In the syndrome, we talk about clinical pathology, epidemiology, etiology, pathogenicity or pathogenesis, diagnosis, treatment, prevention, and control. So there are a lot of research tracks for all of these diseases. And so this was that first book. Where are we here? And look how it's grown in terms of the size of the material. There were, I think, 300 pages in this one, and there are about 2,500 pages in this one, which Judy Wasserheit, who's here, co-authored, along with Walt Stam. So it was clear, becoming clear early, that we needed a lot more than a few people to work on this. And I began going around to the other hospitals and to the different departments to see what kind of problems were we seeing here. And it turned out that there were about 18 specialties listed here that really had a major need for research on STDs and other infectious diseases, and where we needed them to make some progress. And we're able to get help from all of them. Some of them, like the chair of OB and chairs of urology, actually assigned house staff after they were senior house staff to come and work for a couple of years as fellows. And so the time frame of the research that evolved, and I'll go through this not totally time sequence, but more in terms of the bacterial STDs and then the viral STD research that started about 10 years later, and then the HIV research when HIV started in the early 80s, which was more or less concurrent with the beginning of our international and global health STD HIV research. So that's the format for the talk. So one of the first studies was to begin looking at chlamydia, and we were fortunate to have Russ Alexander from epidemiology and Sanpin Wong from pathobiology, and Hunter Hansfield was a fellow then. And I had this question, what was causing these cases of NGU we were seeing on the aircraft carrier? And it turned out that for men with NGU, 42% had chlamydia. For those with gonorrhea, only 19% did. And interestingly, many of these went on to develop subsequent post-gonococcal urethritis related to chlamydia. And for the men in the STD clinic with no urethritis. So clearly, this was the study that really established the association with chlamydia. And then Rick Berger, who was the fellow assigned from urology, became interested in epididymitis. And so we actually undertook a study in which, at that time, epididymitis was considered to be a strain. You'd put a man in the hospital, and elevate his scrotum with a towel across his legs and wait until it cleared. And we were thinking that it might be related to these STDs. So what we did was we anesthetized the regional block, and then Rick aspirated the epididymis and did urethral and urine cultures. And what it turned out was that for the cases that didn't have gonorrhea, we got chlamydia out of the men under 35, chlamydia out of 10 of 13, including 5 of 6 with epididymal aspirates. And for the men over 35, old men, we got coliform organisms, and including out of the epididymis. And for gay men, in subsequent studies, we found the same thing, that they had some chlamydia, but they also had a lot of coliforms, presumably from rectal sex. And so acute epididymitis that formerly had been called a strain, now, due to heavy lifting was the thought, now it was an infection and it required antibiotics. And then Walt Stamm came along as a fellow with Marv and me. And he was interested in the causes of the acute urethral syndrome. And the urethral syndrome was this phenomenon in women who had dysuria but didn't have 10 to the 5th coliforms in their urine, which was the criterion established on asymptomatic women for making a diagnosis of UTI. And so we did bladder aspirations and urine cultures, and we found that the standard of 10 to the 5th bacteria per ml of urine was very insensitive, because when we got bacteria out of the bladder, all the people had greater than or equal to 10 to the 2 in their avoided urine. So it established new criteria for management of UTIs. And secondly, we found chlamydia in 11 of the 42 who had sterile bladder urine versus only 1 of 17 who did have coliforms in the bladder or other pathogens in the bladder. So chlamydia was established as a cause of this formerly idiopathic urethral syndrome, and low concentrations of coliforms or other pathogens were associated with UTI. So the UTI management changed dramatically after that study. And we called it now the dysuria-pyuria syndrome. So then there were differences between men and women in terms of how these lower tract infections led to upper tract infections. In men, urethral infection led to epididymitis, but in women, urethral infection did not lead to endometritis and salpingitis, but there were 2 other syndromes that did lead to endometritis and salpingitis, as well as to complications of pregnancy and infertility. And this, I see Dave Eschenbach here, and Dave was involved in these studies, as was Judy Wasserheit. So the first fellow working in this area was Bob Brunham, shown here with his Order of Canada pin now. And he found that in women with mucopurulent cervicitis, which looks like this, before treatment and after treatment, that chlamydia was highly associated. And chlamydia was established as a cause of mucopurulent cervicitis. Here's a new syndrome in women that had an etiology. And this was added to the standard STD syndromic management guidelines. And then Dave came along, also assigned by his chair to work with us as a fellow when he was a youngster. And he started studying acute PID. And a couple of interesting things really came out of that. First of all, a lot of the men and women with acute PID in those days had Neisseria gonorrhea isolated. And he did peritoneal aspirates on some of these women. And most of those with clinical PID had evidence of polymorphonuclear leukocyte exudate in the peritoneal fluid. And of those with gonorrhea, only 38% had other bacteria. Interestingly, they did. But of those without gonorrhea, 73% had other bacteria. We weren't studying chlamydia in those days. We did subsequently. But that led to the clear establishment of the etiology of acute PID as a polymicrobial disease. And then that influenced the treatment of PID. And during the same study, he made this incredible observation that the Dalcon Shield IUD had been first marketed on the West Coast. And what he found was that a lot of the women coming in with PID actually had the Dalcon Shield. The relative risk was 4.4 for IUD users versus non-IUD users. So that was total serendipity that he picked up on. And it led to withdrawal of the Dalcon Shield and prevention of iatrogenic PID undoubtedly in thousands of women, depending on when it would have been recognized, and to redesign and closer follow-up of IUD insertion. Judy Wasserheit, who's sitting next to Dave, then came along and did further work identifying the role of chlamydia in this syndrome and developing the new treatment guidelines for PID that have led to a whole series of those things. Judy founded the STD branch at NIAID, then directed the STD HIV division at CDC, and then directed our HIV vaccine trial network here in Seattle, and now is vice chair of our department, and she really runs it. So then we had the idea of focusing on prevention of PID, not just treatment. So Andy Sturgakis and Delia Scholes led this study. Walt was also involved. And group health has this closed population, so we were able to select women who were in the high-risk profile for chlamydia, screen them for chlamydia randomly, and treat those who were chlamydia positive. And we found that it reduced the subsequent incidence of PID in the women screened by 56%. So this is quite dramatic, and it led to the current national and now global guidelines for screening for chlamydia to prevent PID. And the evidence is that it does, but we haven't had a big impact on the prevalence or incidence of chlamydia, which is a conundrum that we don't fully understand. And these studies have totally changed the spectrum of PID. When I came here and looked at the charts for OBGYN, they were full of women in the hospital with PID. Dave, how many cases of PID do you see now in your house staff?
We may see 2 to 3 a year.
For the whole department?
300.
Yeah. It's an amazing impact. We're both on a review committee for a study in Pittsburgh, and they are not seeing PID. They see endometritis, but not full-blown epididymitis. So that leads us to endometritis. And Nancy Kiviat in pathology did this study on endometrial biopsies from women who had salpingitis or other evidence of PID. And she defined the criteria now used today, the presence of neutrophils in the stroma of the endometrial surface and glands, and then these infiltrates of plasma cells. This is the main criteria used now for the documentation of the diagnosis of endometritis, PID. And Linda Eckert described the clinical syndrome of this that now is used around the world. Now this leads to an interesting opportunity. We had done these earlier studies of mucopurulent cervicitis and of PID. So we went back to the archived cervical secretions that were collected almost 20 years earlier to look for the organism called Mycoplasma genitalium. Lisa Manhart and Pat Totten led this. And that was because M. genitalium we had found was associated with urethritis in more recent studies. And it turned out that in these archived specimens, M. genitalium was associated with a 3.3-fold increased risk of mucopurulent cervicitis, implicating it along with chlamydia in causing this. Gonorrhea, of course, does it too. And then subsequent studies by Elizabeth Bukusi in Kenya showed that it was also associated with endometritis. You could get it out of the endometrium from women who had endometritis by pathology. And Jane Hitty showed that in Peru it was associated with preterm delivery. So here we're beginning to get into global applications of STD research. So the message is don't ever throw away your specimens from studies like this. And I wish we still had our old epididymitis specimens. I'm sure M. genitalium causes epididymitis too, but nobody's proven it. Elizabeth went on after getting her PhD here. She's now an associate professor with us, but she's in Kenya, where she's director of research and training for the Kenya NIH. And this is her paper showing the endometrial mycoplasma genitalium associated with endometritis. She also started this incredible program with Craig Cohen called the FACES program, involving families in HIV clinics, where they now have 162 clinics in their network with 140,000 patients in care. Now this one, Terry Pfeiffer was another OBGYN resident who came to work with Dave Eschenbach and me, and he was working on what we then called nonspecific vaginitis. And the thought was the organism that caused it, now known as Gardnerella, but then Haemophilus vaginalis was the cause. So the treatment at the time was called triple sulfa vaginal cream. We were very skeptical, but there were, millions of women being treated with this every year. And we wanted to look at comparison in a randomized trial with oral doxycycline and oral ampicillin, which we thought might be better for this particular bug, since sulfa wasn't any good for it. And what we found was two things. The first was that one of the women in the study had trichomonas. So we first treated the trichomonas infection, and it cured the concurrent bacterial vaginosis. And since the triple sulfa had absolutely no effect in dozens of patients, we switched from the sulfa to metronidazole in that arm, and lo and behold, the metronidazole cured all of the cases of NSV, which we now call bacterial vaginosis. And also Terry contributed to what we now use as the clinical criteria for BV diagnosis. So that was quite an accomplishment, and this is probably the commonest vaginal syndrome in women, and now we had a treatment for it, which is still the standard treatment, although it's not perfect. And we did many people here now, including Jeannie Marazzo and David Fredericks, are really defining through microbiome studies the vaginal microbial flora, which actually is leading to new pathogens that probably are related to some of these syndromes that we still haven't made the link with. So then we became interested in complications of pregnancy and infertility, preterm delivery, perinatal mortality, puerperal morbidity, and infertility. I don't have time to go through all this, just to say that a lot of the studies that were led by Dave and Mike Rabbit, Sharon Haley, and others linked chlamydia, bacterial vaginosis, and chorioamnionic infection to these problems in reproductive health. We clearly linked the causes of tubal infertility to gonorrhea, chlamydia, and probably to M. genitalium, although that's not proven. Mike now is the head of maternal and fetal medicine here. He also is the scientific director for the very important Gates Foundation funded Global Alliance for Prevention of Prematurity and Stillbirth. And this is his most recent article on that theme. We've made some progress controlling gonorrhea and chlamydia and preventing these complications, but there's still a long way to go in terms of the puerperal morbidities. So Matt Golden, shown here, he's usually very alert in the morning, as you can see, is now head of the Public Health Seattle-King County HIV and STD program. He did this very important study, which is, we call it expedited partner treatment, but basically allowing partners to either bring the medication to their patients, bring the medication to their partners if they have gonorrhea or chlamydia, or refer the partner to a drugstore where the health department provides free medication. And that was shown to significantly lower the rate of recurrence in the individual patient by, well, significantly. And this has been adopted now in 38 states. He also implemented routine partner notification for HIV-positive individuals in King County. And that, along with a lot of the things that Bob Harrington does and others in the AIDS clinic and the STD clinic, we now have, of all people thought to be HIV positive in the county, 69% are in therapy and viral and suppressed, which I think is the best figures I've seen from the U.S. and competes with England, and there aren't any other countries like that, or states. He recently formed a 6-state collaborative between public health and academic institutions to try to follow our model of linking UW with the health department in this field. So this brings me to the era of viral STDs, which was already going on while some of this other work I described started. But the work began on herpes, extended to HPV, and then, of course, to HIV. So in the 70s, a lot of the fellows coming in studied these approaches that were being recommended widely and used, some advocated by Nobel Prize winners, and that none of them had any effect. Adenine rhamnocyde topical ether, which stung a lot, I can say. Lanoxanol 9, topical idoxuridine, DMSO, and even BCG vaccine to prevent recurrences, all were ineffective in randomized trials. But persistence ultimately paid off, and when Larry Corey came in, we became involved in the use of topical acyclovir, which worked, and then with a randomized trial, and then intravenous acyclovir. And then I've indicated and read the studies that were totally independent of me, that Larry led, and then Anna Wald, that showed that oral acyclovir worked for first episode herpes. Greg Mertz was the PI on that one as a fellow. And Anna just published this interesting study of a helicase primase inhibitor that seems to be even more impressive than acyclovir in treating this infection. There's a long way to go with that. And she's also presented data on a vaccine now that, given to alter the course of existing herpes, decreases frequency of recurrences and decreases the amount of viral shedding with recurrences. So that's very promising. And Anna recently got the Seattle Women in Science Award. We have also had a HPV research team. Here are some of the key players: Rachel Weiner, Denise Galloway, Nancy Kiviat, Laura Kowski, who's retired recently, and Steve Hawes and others. Rachel is now the scientific program director for the 2014 International HPV Conference that will occur here this summer. And she did this famous study, which is what I like to tell students when I talk to them. This is the risk of genital HPV infection among female UW students who came in sexually inactive and or negative for HPV. And this is the rate. So when you graduate, you not only get a certificate, but you have 72%. So this is one of the 7 STDs that are most likely to be fatal. And then Laura went on to lead, along with Jorma Pavonen, the controlled trials, first of the HPV-16 vaccine, that was Merck's vaccine, and then Merck made the quadrivalent vaccine against HPV-16 and 18 plus 6 and 11, and that had 100% efficacy against warts and vulvar, vaginal, or cervical precancer or cancer associated with these vaccine types. Then Jorma Pavonen, shown here in a Finnish sauna with Hunter, led the study that was the European, the study that was with the Glaxo vaccine, which is the bivalent vaccine that also showed high levels of efficacy. So after many years of work by this team of people on the natural history of and risks of HPV and typing them and so on, both Kowski and Pavonen led these 2 major RCTs that are now being scaled up in the States and globally for preventing HPV cancer. So it's a huge accomplishment. So meanwhile, Tom Quinn had come in 1970 to 81 as a senior fellow. Tom is now at Hopkins and NIAID, and he has been very prolific. But when he came in, it was at a very strange time in this period, 79 to 81. My estimate is that about half of the men coming into the STD clinic were gay men with intestinal symptoms. We were calling it the gay bowel syndrome. It was incredibly disturbing, and we decided to study it. And his first paper actually concerned, this was a case that Cy Rubin diagnosed as Crohn's disease. You can see the typical giant cells and so on. Patient actually had a positive rectal culture for LGV strains of chlamydia, was called back in and treated for 2 weeks with doxycycline and cured. And so Tom documented the polymicrobial etiology of these infections. And he found that in 119 men with anorectal or intestinal symptoms in this period, 1980, that he got out of it 3 syndromes of proctitis, proctocolitis, and enteritis. And based on symptoms, anoscopy, sigmoidoscopy, and microbiology, identified 12 causes, including 2 new species of Helicobacter that were isolated associated with proctocolitis. This syndrome has largely disappeared in the AIDS era, but it was at that time that I got invited by a friend to go to a meeting of gay physicians in Chicago. And this was on aspects of STDs in MSM. And I gave this talk, and as he summarized it in his introduction to the meeting, my discussion suggested, I never thought I would be doing this, because I didn't, as I told you earlier, I never said anything about condoms, that behavioral and sociological factors may well be the most important areas of research and modification in the battle against the growing list of STDs. And here's what actually evolved. It was a year later that the first PCP and Kaposi sarcoma were seen in gay men. It was called gay-related immunodeficiency syndrome. And then as HIV was identified and began to grow globally, this became a big focus of our efforts and everybody else's. We also began to work internationally more actively at this point. And that was because we had a fellow, Joan Christ. Her husband, Roger Perlmutter, was head of immunology at that time, which was why we were lucky to get Joan as a fellow. Wanted to study HIV in sex workers in Kenya. And I said, well, you know, there isn't any HIV in Kenya, and it's only been seen in Rwanda and Zaire. But she persisted, and lo and behold, what she found was that, let's see, that in the low SES female sex workers, 66% had HIV already. Totally unknown. The Kenyans couldn't believe it, accused us of lying, and there was a high association with genital ulcer disease, you can see here. And actually, this was the first evidence of association of HIV with genital ulcer disease. And she showed that most of this genital ulcer disease was chancroid by doing cultures, which are insensitive, isolating Haemophilus ducreyi. And this launched a big HIV/AIDS research in Africa. And then Ruth Greenblatt, working with Sheila Lukart, went on to study this in men, and she found that in men coming into an STD clinic, that a history of genital ulcer disease was also highly associated with HIV. So here we have the first data in individual patients linking genital ulcers to HIV, and it led, as I'll show you, to new guidelines that I think have had an impact on bringing HIV rates down in areas where these were very common diseases. She also found that in male circumcision was more common. Let's see, I think I got this reversed here. No, in the HIV positive, most of them were not circumcised. But in the HIV negatives, most of them were circumcised. And others were looking at this at a regional level, but she was the first to show it in a group of individual patients. So this study, first by Joan Christ, then by Ruth Greenblatt, followed by others working with the Manitoba group, helped motivate the WHO guidelines. And I went to the WHO for a year for sabbatical to work on this, for syndromic management of STDs, including genital ulcer disease. And I'll show you what happened concurrently with that. We can't say this caused the disappearance of chancroid or the impact on HIV, but I will tell you that the first time I went into the STD clinic in Nairobi, I saw 5 cases of chancroid in the first half hour. And they haven't seen a single case of chancroid in Kenya since 1997. And Sheila got the Seattle Woman in Science Award last year. This is what's happened to these infections. In Durban, you can see that in South Africa, Haemophilus ducreyi, the cause of chancroid, basically is gone. Syphilis largely has disappeared, not just syndromic management, but largely. And this is what's happened in terms of trends of HIV globally. Now, these are global trends, but the slides looking at Africa, sub-Saharan Africa, are virtually the same, since most of the cases are there. And you can see that although antiretroviral therapy that was effective was discovered in 1996, it really wasn't rolled out in Africa until 2005, 2006 with PEPFAR money on the Global Fund. But you can see that rates of HIV were dropping already in 2000, 2001, and they've been steadily dropping in terms of incidence with no particular downward inflection. And I think a lot of this is due to syndromic management of STDs, to not much increased condom use, but I'm sure some changes in sexual behavior, although it's been difficult to document. A lot of this is based on studies of pregnant women. And then another HIV study that has had a big impact was led by Ruth Ndwati and Grace John Stewart, who worked with Joan Christ. They were interested in what proportion of perinatal transmission of HIV was due to breastfeeding, and they found that 44% of infant HIV infection, and all women were breastfeeding in Africa, was attributable to breastfeeding. And the HIV survival at 2 years was significantly lower in the breastfeeding arm of this randomized trial of breastfeeding versus formula feeding than in the formula feeding arm. And this led to more studies of safe breastfeeding, and it appears that exclusive breastfeeding is relatively safe, although it's now coupled with antiretroviral therapy and PMT, prevention of mother-to-child transmission. But this prompted cessation of the non-exclusive breastfeeding, and undoubtedly it's had a big impact on postnatal HIV transmission globally. And then back at home, Mari Kitahara leads the data program for what's called NA Accord and for the group of HIV clinics with electronic medical records. She published this paper in 2009, and it had a huge impact on HIV therapy globally. She showed that comparing early therapy, i.e. above 350 CD4, above 500 CD4, versus deferred therapy to below the standard of 250 in those days, that in the deferred treatment group there was a 94% higher relative risk of death. So this changed guidelines, and it has continued to be a total change. Now we also have new evidence for pre-exposure prophylaxis for prevention, giving antiretrovirals. And Javier Lama was second author, but enrolled most of the patients in the IPREC study, which showed that daily oral Truvada for MSM, who were HIV negative, had a 43% drop in their HIV acquisition. More impressive was a study led by Jared and Connie Kellum, the Partners PrEP study, in HIV serodiscordant couples, in which the seronegative member of the couple took tenofovir or Truvada, and there was a 72% reduction in the Truvada arm of HIV acquisition, and this was over 90% for those who were actually adhering to the drug. So that led to the FDA approving antiretroviral prophylaxis for HIV prevention in heterosexual men and women. And this is now being studied further in terms of real-world effectiveness. This was a study I was involved in with Patty Garcia, who's now Dean of the School of Public Health, then had just finished her fellowship here, and on prevention of sexually transmitted infections in urban communities. And the idea is getting into multi-component studies, which is where the fields are going now in terms of STD and HIV prevention. So in this study, and Patty, by the way, got the Peru National Women in Science Award last year, so a lot of these women are being recognized. The study showed that in female, this was an intervention that was multi-component, I won't have time to go into it, both in female sex workers and in the general population. And we measured the outcome in random samples of sex workers in 20 cities, and you can see a lot of them were studied, and in households. In 20 cities were randomized, 10 intervention, 10 control. In the sex workers, the intervention decreased the prevalence of the 4 major curable STIs, chlamydia, gonorrhea, trick, and syphilis, by 35%. First time that has been shown in a community randomized trial with sex workers. And similarly, in women in the general population, these household samples, 24% reduction in the combined prevalence of any of these 4 diseases. Again, the first time. So this is really pushing people for both HIV and STD into these not simple interventions, but complex interventions. So this is me in my last grand rounds talking about complex interventions. But it isn't that complex, and it's what we're all beginning to do. And the other area where I've been more actively involved as PI of this program now, called ITEC. It's the university's largest externally funded grants, about $85 million this year, and it's funded by the U.S. government, and we work in 22 different countries. And ITEC stands for International Training and Education Center for Health. Ann Downer is the director, and it involves lots of interventions. We have trained and educated some 185,000 people, I think, at this point. And we are helping with implementation of many programs. The programs are most active in sub-Saharan Africa. So to summarize, the impact on women and children's health has been that we now understand STIs much better. They're better managed, they're less common, and the complications are rare. Cervical cancer is 70% preventable by the current vaccines in terms of coverage of the major oncogenic types 16 and 18. And the new 9-valent vaccine from Merck will cover 92% of these cancers when it's ultimately approved, which we expect will be sometime this year. There's been a major impact of ending postnatal HIV transmission via breastfeeding. PID is a disappearing disease, as you heard from Dave Eschenbach. Ectopic pregnancy, almost gone. Would you agree with that, David? and at least due to STDs. And tubal infertility is much less common. Vaginal infections are now better diagnosed and better treated. And although trichomonas and BV are still seen commonly in women coming into the STD clinic, for example, they're very uncommon in the kind of practice that we have at our OBGYN clinics here. Perinatal morbidity, there's been some impact, but a lot yet left to do. And we're no longer spreading STIs with vaginal speculum, proud to say. In terms of men's health, there's effective treatment now for urethritis for all of the different types. Epididymitis is now a rare disease, just like PID is. Intestinal infections and MSM are understood, well managed, and still less common. And anal cancer, probably, although we haven't got the data, is about 70% prevented by the current vaccines, just as cervical cancer is. There are other cancers caused by HPV. Oropharyngeal is probably going to overtake cervical as next most common, and anal cancers in MSM are quite common. So in general, men and women, HIV mortality has been greatly reduced, but the U.S. incidence is still unchanged at 50,000 new cases per year. And earlier ART will be key, but this is concentrated in high-risk populations, particularly in MSM and in the South. Chancroid, gonorrhea, and syphilis are well controlled, except in MSM, as I'll show you. My first studies here were on disseminated gonococcal infection. I used to review charts of hundreds of cases here. It's gone. We have increasingly effective treatment for herpes and for preventing transmission. Herpes, I didn't talk about it, but hepatitis B virus and HPV incidence are declining substantially. We've shown that condoms are effective for all of these. HIV-related cancers, not only cervix, but these other ones, will be controlled by HPV vaccines. Hepatitis B-related liver cancers and cirrhosis will be controlled. And UW research showed that condoms prevent all of these three. Early ART lowers mortality, PrEP prevents transmission, and the ITEC program is having an impact in low-income countries. We have had super mentors here. This isn't a complete list, so I won't list them all, but some of these people have had as many or more mentees than I have. But, and here's what was happening with the AIDS epidemic in the AIDS era up until 1996 when HAART was first reported. You can see that we had a paper actually that Laura Williams and I submitted called Elimination of Primary and Secondary Syphilis in King County. We proudly submitted it. And here's, don't ever do this, because what happened was the advent of ART was recognized and reported in 1996. And this is what happened afterwards. So undaunted, we sent the paper back, Elimination and Reintroduction of Primary and Secondary Syphilis. But this is not good. You can see this is mostly among MSM. And look what's been happening. I'll skip this slide and just show you for King County. This is what's happening to gonorrhea, really well controlled in heterosexual populations, but way out of control in MSM. And early syphilis, well controlled in 17 cases in the heterosexual population. But the number of reported cases is this is the highest we've ever had since recorded time, and it's almost all in MSM. And this is the estimated incidence in MSM by HIV status. So these are estimates. But you can see, interestingly, almost all these cases are happening in HIV-positive MSM. And we think this is related to the trends towards more concentrated groups of MSM having unprotected sex. This is so-called serosorting and seropositioning, where HIV seroconcordant partners have sex together. And this is a smaller group of high-risk men in densely connected networks and leading to this high STI incidence. So the remaining challenges, and I'm close to wrapping up here, are that for HIV, we clearly need a vaccine and a cure, and we're working very hard on that. The Hutch is leading the way in both of these areas. Neisseria gonorrhea, I didn't get into it, but we now have antimicrobial resistance to virtually all of the drugs, and the only thing that we are hanging on to is injectable third-generation cephalosporin and ceftriaxone. But we're beginning to see lessened susceptibility to that. And chlamydia trachomatis it's this strange phenomenon where the complications are greatly decreased, but the prevalence is still staying high. Modelers are giving us some reasons for that. For most STIs, the rates at MSM are high and increasing, and that remains a major issue. And it's also true in increasingly concentrated in poor populations, minority populations. And in terms of STE programs, some are being dismantled, and I hope you're all aware that this was recently threatened at Harborview, but there's been reassurance that the program will continue at the world's best STD program. Half of the common syndromes, like NGU, mucoperineal cervicitis, PID, and genital ulcer disease, actually are still idiopathic. We don't know what causes them. I think microbiome studies are going to help us with that. We have better control of all of the 7 STIs that are sexually acquired that are most likely to be fatal. And you can speculate yourselves about what those are. I will make you think about it. There are 350,000 complications of syphilis in pregnancy every year globally. We used to talk about congenital syphilis, but now we're lumping abortion, preterm delivery, stillbirth, and congenital syphilis. And there's no integration of screening for HIV, which is everywhere, and screening for syphilis, which is nowhere, even though syphilis is easy to treat. We need vaccines for HIV, obviously, herpes, there's hope, gonorrhea because of resistance, chlamydia because we're not lowering the prevalence, and for syphilis. And we need the cure for HIV for obvious reasons. We have it for hepatitis C now, but it costs $84,000 a year. How we're going to prioritize that? Partly a sexually transmitted disease, mainly injection drug use. Herpes, we need a cure. Gonorrhea, we may need to find new cures. And M. genitalium, I didn't get time to go into it, but amazingly high frequencies of existing and developing resistance to the major antibiotics, even like moxifloxacin. So this was a gift from Tom Quinn, and these are some of my former trainees and current mentees and colleagues, and many of them have their own now. So, and they've come here from 18 departments and multiple schools and colleges. So I want to especially thank Marvin Turk, my mentor. He got me started in lots of ways. I want to thank Bill, too, who's been generous enough to loan me to Global Health for 7.5 years now. And thank you.
I have one, Dr. Holmes. I was wondering, locally, what's the rate of gonococcal resistance here in Seattle?
2 years ago, it was increasing, and we were using oral Syphilis, and that after Cipro became so commonly non-sensitive, Cipro was abandoned as a first-line drug several years ago. And about 3 years ago in the U.S., we abandoned Syphilis as a first-line drug. We still give it, but the treatment recommended now is ceftriaxone. What's happened recently is that the level of decreased susceptibility to Syphilis has begun to drop the last year. And in Canada, where they've been not giving single-dose Syphilis, but giving 2 doses of Syphilis, it's dropped. And in England, where they upped the dose from 250 to 500 milligrams of ceftriaxone, the prevalence of Syphilis, less than susceptibility, has been dropping. So we think that we may be able to forestall this by being strategic in how we use the more effective ceftriaxone. I should have said ceftriaxone doses were increased from 250 to 500. So anyway, we'll see how it goes, but it's very worrisome, despite what I said. Marvin?
The thing that I most recognized is if you have a superstar coming he doesn't need a fellowship. So what King didn't have an infectious.
Oh, you let my secret.
He was appointed to the faculty. So I made the right choice.
Thank you. My fellowship was actually my year as chief resident with Marv. That was a lot of ID.
Maybe you repeat the question, but I've been reading a lot about smallpox eradication. Do you think any STDs can be eradicated?
Well, I think chancroid is being eradicated, for example. Even in places like India, I went for one visit to Chennai, it was Madras, and I went through the ward where it was all genital ulcers. And one of the second worst things I ever saw in medicine was they went from, it was a huge room like this one, and beds after beds full of people with granuloma inguinale and chancroid. And they had wore gloves, but they'd go from patient to patient to patient. They didn't change the gloves. And the idea was to protect the doctor, not the patient. And I think now chancroid is largely disappearing there. But, we've had effective treatment for syphilis. There was a program that Judy actually led when she was at CDC, aiming to eliminate syphilis. And if it weren't for the epidemic in MSM, it probably could have been better controlled. So I think with vaccines, we have the chance. I think take a vaccine like HPV. In India and Peru have both stopped rolling out the HPV vaccine. In India, it was because they saw some complications in women. They had nothing to do with the vaccine, but they just said no more HPV vaccines. It's going to cost tens of thousands of deaths due to cervical cancer. In Peru, much the same, but for political reasons. So it isn't simply just having the tools, it's the implementation. TB is a good example. We're working on a volume with Barry Bloom, the TB person. He says if we had all the diagnostics and all the treatments we would ever need for tuberculosis, we would never be able to make a difference in tuberculosis. And he's talking about that because of the need for interventions and health systems that work. And the more we focus on that, and it's certainly a big emphasis of what we're trying to train people to do and help them do in global health and with ITEC and so on, the bigger the chance we'll have of having a bigger impact.
Thank you, Dr. Holmes.
Thank you.
Thanks again. I thought it was great.
Thank you. It was a pleasure.